Today I'll be presenting my project on a novel surgical procedure for reconstructing a large glenoid defect. So to refresh you all on the background of my project, I just wanted to give you the sort of patient who would be interested in my project. So here we see professional NBA player Kevin Love playing for the Cleveland Cavaliers. Now in the 2015 NBA playoffs, he unfortunately had this run-in with Boston Celtics player Kelly Olynyk, which for Mr. Love resulted in an anterior shoulder dislocation. If he's lucky, relocation of the humerus will result in good long-term outcomes for his shoulder function and stability. But we also know that about 70% of patients presenting with a recent dislocation have damage to their anterior glenoid. This can be due to a fracture or an erosion, and we call it a glenoid defect. If it's greater than 20% of the glenoid area, we refer to it as a large glenoid defect, and it's associated with significant morbidity and a very high chance of recurrent dislocation. That's why most surgeons consider this the indication for surgically reconstructing that glenoid with a bone fragment. Here we see in the Eden-Hibernate procedure that a piece of tricortical iliac crest has been fixated against the anterior glenoid. The Bristol-Latouche is a similar technique, although it uses the adjacent coracoid from the scapula, leaving the short head of the biceps brachii intact to act as an additional anterior sling. But important to note is that both of these procedures use two bicortical metal cannulated screws, and this presents a problem to surgeons because we know that the vast majority of negative consequences coming from this procedure are related to the insertion of these screws. This includes neurovascular damage due to the close relation of the brachial plexus and branches of the axillary artery. We also know that insertion of screws can lead to bone fracturing and can even invaginate the joint space, which massively risks premature osteoarthritis. This probably explains why 34% of patients at long-term follow-up had a revision surgery just to remove the screws. On this basis, and also taking into account that screw-free techniques haven't been investigated well in the literature, the aim of my project was first to design a completely novel technique for reconstructing a glenoid defect that does not use screws, and to furthermore assess its efficacy biomechanically. So on the basis of these aims, my methods were as follows. To design a technique, I needed to consult with experts in their respective fields. This included people who worked at orthopedic device companies, as well as Dr. Patrick Lamb, who was a professor of biomechanics, and my surgeon, Professor Morell, who talked about applicability to the surgical environment. But I also read past literature to get inspiration on techniques, but ensure that I was doing something that had ingenuity involved. What followed was grueling trial and error in the laboratory. We would bring in these orthopedic device company reps, and we would test out with sample devices on here we see an artificial glenoid. So this is sort of fake bone, if you will. And we tested out a number of techniques and gained a lot of insights from this process. To investigate it biomechanically, what we did was we took cadaveric sheep shoulders that were dissected of all soft tissues and tested them over 3 states. We had 2 groups of 8, with one group being tested in the intact state on the left, and the other group being tested in both the defected and repaired states. We were able to quantify stability of the shoulder joint by using our in-house Instron apparatus, which translates the humeral head against the glenoid at a standardized rate and records the force transduced by this dislocation. This leads us to our results. Firstly, into the technique I designed. Here we see a glenoid where an artificial glenoid defect has been created that is 30% of the glenoid by width. We've drilled holes in the glenoid, in the fragment that we've created, and this will be crucial for the repair. We then tap 3 holes in the glenoid, or I should say the scapular neck, with an obturator. And then we insert 2 suture anchors, which are generally used for soft tissue repairs, such as a labral reconstruction. We can then thread the sutures emerging from these anchors through the graft and incorporate what we call an endo button, which can be thought of as a metal buckle, which will help us with tensioning and optimal fixation. By tying a knot in a suture end from each of the anchors, we effectively create one large loop of suture that is running through the graft and both anchors. By then pulling on the 2 outer suture ends, the graft slides down to nicely adhere to the glenoid structure. We can tension both of these outer sutures equally before loading them into a 3rd final anchor that will be attached superiorly at what we call the offsite. This leads to a fully tensioned mechanism and sort of improves apposition of that graft against the glenoid. What we are then able to do is we're then able to take this complex and load it into the Instron machine, which we are seeing here. The humerus is on the left and it's being translated downwards, which in this case is antero-inferiorly on the glenoid. We can see that the graft is eventually loosening and being translated medially. In the intact state, where the bone is attached, there would be fracturing, which is the reason why we needed 2 groups of 8, with 1 group being tested in the intact state. What the Instron machine gives us is a force displacement curve, which we can see here. Essentially, it's showing us load that's being transduced while the humerus is being displaced. Most important to gain from this is that each individual grey line is a specimen's results, whereas the large bold green line is the mean of the results, and the dotted line the standard deviation. This is for the intact group. It reached 230 newtons approximately at the peak. You can see when the defect was created, that group had a significantly lower force displacement curve, which means that it is having also a significantly lower stability of that joint. And when the repair was performed, there was major improvements in that stability, approaching back up to the intact state. But if we actually want to analyze these results for the magnitude of stability improvements as well as statistical significance, we can't just look at the curves. We need to take specific time points and analyze those. For example, here we see the force required for 2 millimeters and 4 millimeters of displacement respectively. Between these groups, there was statistical significance. Most importantly would be the average peak force, shown here, which can be thought of as the force required for dislocation of the shoulder joint. Again, this showed statistical significance, with the repair leading to a doubling in stability and being approximately 70% of the intact state. We also had secondary outcomes. We looked at how accurate the graft placement was and found that it was always within 2 millimeters of the native glenoid surface. We also found that the repair was quick at less than 12 minutes, and there were no cases of the mechanism rupturing or obliterating, but rather the graft was able to translate immediately, which allowed the dislocation of the humerus. So what does this mean? What do these results mean for our study? Well, the repair significantly improved the stability of the defective glenoid by a magnitude of between 2 and 3 times, depending on the outcome measure. Additionally, the technique was able to achieve between 70 and 75% of the stability of an anatomically hard bone intact glenoid. Finally, the fixation was quick, accurate, and not susceptible to obliteration. We can also postulate on some of the potential advantages and disadvantages with these results compared to screws. For example, we may potentially with this technique eliminate or reduce the majority of screw-related complications because the anchors are smaller, made out of plastic rather than metal, and are less traumatic to insert. The tensioning mechanisms and pull-down mechanisms that I described earlier have yet to be described previously in the literature and benefit this procedure for its arthroscopic ideal. However, there are some clear limitations that have emerged. We never expected that this technique would achieve the same fixation strength as screws or that it would reach the intact state. But does this matter? There have been small clinical studies performed by Zhao and Alfoff that have shown that when using a screw-free technique with just simple knots, there were still good clinical outcomes. However, we might be able to say that this would not be applicable to grafts that are under constant load, such as the Bristow-Latouche when the coracoid has the short head of the biceps attached. Additionally, further speculating, this might incur a longer period of immobilization to allow for proper fusion of that graft with the primary glenoid. There were limitations to the study, namely it was an animal study and we had all soft tissues dissected, which would have improved stability for all states. We had a small sample size and non-parametric statistical tests were used, however these all showed significance for each comparison. The technique was not performed under standard surgical conditions, but we are currently looking at assistive orthopedic devices that may help with transitioning the procedure to the operating theatre. And finally, it was not comparative between techniques, which was due to device limitations. In conclusion, this study presents an entirely novel technique that shows that has intrinsic benefits over screw fixation. Additionally, the workup suggests that while we couldn't reach the intact state, we did get close, and there were large improvements in stability over the defected state. We have gained procedural insights from performing this that would be relevant to all screw-free fixation techniques, not only for glenoid reconstructions, but potentially for repairing any type of avulsion fracture. And finally, this paves the way to future human cadaveric studies as well as clinical outcome studies. I would like to outline my contribution here and my acknowledgements. Here are my references. Any questions?